Thank you. Dr. Luke Evans.
Thank you, Chair. And my question starts with Sir Simon Stevens. Last time when you came and gave evidence to us in January, I asked about red tape and bureaucracy. I'd like to follow up some questions on that. In your answer, you split it into two sides, the patient frontline side and the administrative side. I'm keen to go down the administrative side in light of the white paper of what's been put in place. You pointed out that 2p in every pound was spent on administration. In Germany and France, it was 5 or 6p. Does that mean we've got the level right in the UK?
Sorry, Luke, you mean that the level of
cost of administration? Yeah.
Well, as you rightly remind us, our administrative costs are low, but what we are suggesting is that some of the requirements that are placed on the health service actually still nevertheless generate wasted administrative effort, and it would be good to be able to dispense with that legally induced bureaucracy, and in particular the requirement to competitively tender many aspects of care that don't would have right. No benefit from whatsoever. It would be good to be able to drop that requirement.
And that's the element that comes out in the white paper of reducing bureaucracy. Could you explain what it means we've come from and where we're going to with the white paper regarding competition?
Yes. Well, if I pick up the prompt, particularly starting with the procurement point, as a combination of the Section 75 of the 2012 Act and the Public Contract Regulations 2015, the combined effect of those two is that we do frequently find ourselves running competitive tendering processes where there is a presumption that those services will be tendered out if the value is more than £663,000, and that can lead to some pretty spurious processes where you tender out some community nursing but not some other parts of nursing, you fragment. We frankly went through the farcical situation of having to put out overdue procurement documents for the nation's specialist cancer services, cardiovascular tertiary services and so forth, because they were obviously more than £663,000 worth. And yet, the reality is who's actually going to come and be the replacement for the Royal Marsden or Guy's and St Thomas's or Central Manchester Foundation Trust and so on. I mean, so there's a lot of spurious activity that is generated off the back of those things, but it does mean that parts of care get fragmented, and that's what we want to dispense with.
I'm really keen you point that out there. That's a prime example. So can you give us a feel? What does that mean for either money saving or time saving? That this have you done projections as the NHS of what this would actually look like practically?
Well, we've certainly spoken repeatedly down the years to frontline staff, to our colleagues, NHS leaders who are having to operate this system, and this is one of the clear points they have put to us. Until now, our hands have been tied by virtue of a combination of domestic and EU legislation. Now the bill has the opportunity to step beyond that.
And so could I pick up some points on procurement potentially for Amanda, if that's okay? So Simon's mentioned it to Laura, and now in these points as well, particularly around goods. The Institute for Government talk about the NHS supply chain looking to account for about 80% of procurement by 2022. Is that still the case? And again, how does this legislation free up the procurement? Procurement's been in the news a lot during the pandemic. So what difference would the public and indeed those who work in the services expect to see around this?
Yes, thank you. I mean, this legislation or the proposed legislation is much more about services actually than goods. So as Simon says, it's really designed more around where we have services which are tendered out, which can be and often are very small parts of community services, although we do have those sort of examples of where huge specialist services have had to go through the same process, and making it easier to avoid having to go through kind of multiple competitive tenders. So I think, as Simon has said, we've got, countless examples of where, because of the way legislation or the way the law is currently described, actually what people have done is gone for very short-term, very inflexible contracts that have been then had to be re-let almost year on year, which means in practice it's a big overhead of time and cost, but we also lose the opportunity to really think about continuity. We often lose good leadership on the back of that, but really it works against integration of care at local level, and that's the main thing we're trying to fix here. So I think that the primary benefit here is going to be about the local physiotherapy service, the local podiatry service, the local speech and language service, and that's the opportunity now with a proper framework in place, not just to roll things over without due process around looking at value for money, quality, patient feedback, etc., and clearly an expectation of continuous improvement as part of that, but to allow a different process that doesn't require that same sort of formalised procurement arrangement.
That's really helpful. I'd like to step this a little bit wider because in the bill it talks about reciprocal healthcare. We've had Brexit now. And so Simon, what do you see the benefits and fallbacks of the reciprocal arrangements put in place? And how much of a problem is it, and what will this solve?
Well, I think that's primarily a question, if I might say so, Luke, for Matt Hancock when he's with you next week. That's a DHSC, a government judgment on reciprocal healthcare, but clearly there have been benefits in British citizens being able to get healthcare out with their travel insurance when they are travelling and vice versa. But it's been quite a complicated regime, I think it would be fair to say, hitherto. And so putting in place something, and there are transitional arrangements, but those ultimately will be judgments for government rather than for the NHS.
If we invert it though, because it does talk about no healthcare system should be out of pocket, what's the scale of the problem for the NHS currently, and what would that look like with the new changes for the NHS itself? Because it's a two-way street.
I think it's. I'm happy to, on your behalf, ask the department to come back to you on that, Luke, based on the estimates that they've drawn up.
Thank you. And the final question I have on this side is moving to the public health aspect. You picked up on fluoride. One of the things I noticed is food standards is being put on a legislative footing. How will that affect the NHS, and why does that need to be put in place in the first place?
Yes, this is standards for hospital catering for food. Look, the underlying argument, which is a long-standing one, is that nutrition is vital for people's health and recovery, and so ensuring that those proper standards are in place across hospitals is obviously a good thing to do. Now, if that's going to be the case, we're going to need to make sure that hospital food has got the right resourcing. The Hospital Caterers Association is doing a fantastic job. We've had the review with Prue Leaf recently, building on other reviews as well. So there's a real appetite on the part of hospital caterers, I think, no pun intended, to drive change and improvement in this area. And the government has said that they believe it would be useful to have the ability to set some of those standards statutorily.
And so, Simon, do you think that should extend there to the care sector then, and care homes and residential homes?
Well, I mean, it's an interesting question. If it, what is it? What's sauce for the goose is sauce for the gander. But I think, there is a slight risk here that one gets into statutorily trying to regulate lots of different input elements into the way care is provided. Whereas if you're looking at a rounded view as to what counts as high quality care in a care home, then obviously, perhaps channeling your chair, the CQC has a responsibility to do that, as well as the publication of transparent information and the choices that people are able to make as well. So, I don't think you can second guess every aspect of what high quality care looks like by trying to pass an act of parliament. That actually will just gum up the ability for people to do the right thing and innovate. And that's the spirit that we've seen across the health service, across the care sector over the pandemic, the last year. It's that sort of can-do spirit, frankly, with more initiative and autonomy devolved to the front line of care that we want to see, rather than more centralised second guessing and command structures.
Thank you very much, Chair.